Should I start?
Yes, go ahead.
Okay, okay. So thank you very much. First of all, I would like to thank the PSYOP Nursing Network for inviting me to share a case of grief and bereavement. So as you can see that in end of life, we try to add life to patient's days rather than adding the days to his life. So whenever we are dealing with the patients with the end of care, we are always try to add life to the patients. So I am Dilnasheen Safdar. I am Director of Nursing and Infection Prevention and Control, HOD Bone Marrow Transplant Nursing Team at National Institute of Blood Diseases and Bone Marrow Transplant, Pakistan. So I'm a member of PSYOP, PIDS, AFON, HIS, and also the European Bone Marrow Transplant uh, IDW party. So I'm the first nurse in Pakistan who established the bone marrow transplant unit in public sector in Pakistan and receive a Nurse Leader Award from the government of Punjab, Pakistan. I received Master of Nursing Award 2022 from the Global Power of Oncology Nursing. I'm also elected as the steering committee member of Global Power of Oncology Nursing UK. And luckily, I'm a part of the pioneer for the palliative care in Pakistan and represent from the nursing side. So as the palliative care in Pakistan is in infancy phase, so we are trying to establishing the palliative care, the end of life care, and the grief and bereavement in Pakistan. So I am the part of that team who is pioneer in Pakistan. I'm also honored as the first Asian nurse selected as the European Bone Marrow Transplant IDWP 2024. So this is me. So as the Pakistan background, the Pakistan is a low middle income country and the total population is estimated at 242.8 million. And semi-industrialized nation, the 20.9% of GPD is agriculture based. Current GPD allocation on health is less than 3%, about the half of the minimum of WHO recommendation. So that we are still struggling for the providing the health and providing the healthcare services to our population. So it is very hard for us to allocate any budget for the palliative care in Pakistan. So this is a distribution of cancer center across the provinces in Pakistan on a background of population density. As you can see that Punjab province is the mostly populated province in Pakistan with a high number of cancer center. But unfortunately, we don't have any palliative care center, any hospice, or especially in the public center. In Pakistan, we only have one palliative care team in Karachi, that is in Sindh, Khan University Hospital, and the second one is in Lahore, that is the Shaukat Khanam Cancer Hospital. And in the other hospital, we have a small teams, and we try to gather them, and we try to unite them to work and to train for the palliative care. So back to my case, that is the grief and the bereavement. So I try to communicate and I try to explore that what is the feeling of the parents after loss of a child. How make last day of child a good memory? What measures can be taken? Keep child comfortable, pain-free, and asymptomatic at the end of life. What is the role of oncology nurse? What are the best strategies for managing the situation? And what is the role of a nurse deal with the family? So I want to share some definitions. That is the grief. Grief is a process of psychological, social, and somatic reaction to the perception of loss. And mourn is the cultural response to grief. When we talk about the bereavement, is the state of having suffered a loss. And the grief work is the work of dealing with the grief requiring the expenditure of physical and emotional energy. So we all should know, when we are working in the palliative care, we should know about the grief work, because we are dealing with all these things. So my patient, I want to share the detail of my patient. That is a 8 years old male patient with primary diagnosis of beta thalassemia major. And the prevalence of beta thalassemia is very high in Pakistan because of the cousin marriages, the inter family marriages, and you know that only the curative treatment is the bone marrow transplant. So the patient came with the chronic GVHD lungs, which is very fatal, and it's very expensive complication of the bone marrow transplant. And he have the siblings, 4 sisters. So he have 4 sisters and only 1 brother. Treatment and significant investigations are on initial visits. The siblings are screened for the HLA, which was not matched with the patient. And this situation is very hard for us because the 4 sisters, they are not matched with the brother. So the parents have stressed us for the treatment because they want to save the boy, they want to save his child. So we go for the haploidentical bone marrow transplant, which was done with the father because the mother was pregnant at that time. The post-transplant, he was on immunosuppressant, antifungal, antiviral, and mouthwashes up to 100 days. Weekly follow-up with the CBC, RFT, LFTs, and Hickman and dressings up to 3 months. Monthly follow-up up until 100 days. And we did the donor chimerism day 30, 60, and day 120, which was more than 90% post-transplant. And when we are talking about the course of illnesses, that the post-bone marrow transplant engraftment was good. His follow-up up to 1.5 years was very smooth. But after the 1.5 years of the transplant, patient developed the chronic GVHD lung. And he is developing it gradually, and came to the hospital on and off. He developed difficulty in breathing, her HP was dropped, and he complained of the pain in the chest, anorexia, and weight was declined up to 20% of the baseline weight. He was unable to walk, emotionally very disturbed, and he was not willing to stay at hospital because he always very angry with the prolonged hospitalization. He is very social boy, and he was very happy to live with the cousins, with the sisters, and with the friends. So he always angry to stay in the hospital. So pain and the symptoms and the relevant treatment is that dyspnea was developed gradually after 1.5 years of the transplant with a slight pain, and HP was dropped. The parents were very concerned on the drop of the HP because he was a thalassemia patient, and they are living in a village and not well educated. So the criteria for them that transplant is very good is the hemoglobin. So when the child, the hemoglobin became dropped, and there's an interference with the daily activity of the child, they are very worried about that, because they want the HB should be on the normal limit. The physician advised for the HRCT, bronchoscopy, and tissue biopsy, which shows for the chronic GVHD lung. So we start the first line steroid and started with the paracetamol for the pain, but it was not resolved. So we switch on the injection solomedrol, and starting along with the tramadol for the pain, and rituximab and other treatment of the chronic GVHD was also added to the patient. But the condition worsened day by day, and he need on and off admission due to desaturation, that is the 80%, 85%, and 88% continuously, which was very difficult for him. And the symptom assessment for this, we are assess the pain scale on the on the pain scale, and numerical rate scale was used. Initially, his score was 8, but day by day it was worsened, and at the end of life, his score was 7, which was very difficult for us to see him. So we try to support the child and the family with the psychosocial and family concerns are addressed with our team. Mother and father was in denial phase because he is the only main child of the family with 4 sisters. They had unrealistic goals for which they were counseled because they are not accepting this, that after 2 years of the transplant, the boy was very doing very well, and 1.5 years after, he suddenly developing that dyspnea and all these symptoms. And the child wanted to go home because he wants to see friends and cousins, and he wants to buy cold drink from his corner house shop. And he, because he was very fond of that soda, and he always liked that shopkeeper, and that shopkeeper loved the child very much. So he always remember and always talk about that person. So we send him with the oxygen support and nebulization, which improve his oxygen saturation. So we respect his wish, and we arrange all these things, and we arrange a ambulance, a car for him, because he want to visit a zoo, and he want to visit his family. So we arrange all these things, and when we give him proper nebulization and oxygen, he feels better with the cousins and the family. We give all, because the family was not much financially sound, so we arrange all these medicines, oxygen cylinders, nebulization machine, and we provide all these things free of cost because the financially constrained. So spiritual concerns are also addressed. The family was Muslim, and the father accepted the fact that it is will of Allah and was content. Mothers were also counseled because she wanted the cure for the child. Counseling was done on the religious ground. On one of his brother, he counseled with the help of a nurse who was continue in touch with her and very close to the mother. She shared all the concerns and all the things with the nurse, because that nurse was with the patient and the mother throughout the treatment. So the communication was communicated to the family that we have no curative option, but we can make sure that child has comfortable transition. We reassured his family that we will be there till the end and will try to manage all his symptoms. Her mother was afraid to enter in the room. She cannot see her child in such condition. We encourage her to see and talk with him. He wants to see you, because at the end of life, the child, he only asks for his mother. So we the nurses and the physician, we counsel the mother. We try to convince her that face this situation. You spend a very good time with your child. This time he needs you. He want to talk with you. So we encourage her, and she accept this. This is very difficult for us because the child was very, every child is very beautiful and very close, but he was very close to us. So she stayed with her son. She talked with him bravely, and that was the last day of that child. After death of child, will leave his mother and father with the child alone. She took him in the lap and cried and talked with him. for at least 30 minutes. So we leave them alone, and we want that she talk with him, and she saw her. So collaboration and partnership. We do not have psychosocial team to address these issues, but the nurses, physician, and oncologists collaborate to make the journey of the child and make smooth end of life comfortable with the limited resources. As I shared before, that in Pakistan, the palliative care concept is in infancy. We have not proper team or any training for the nurses, any training for the physicians. We have only 2 trained physicians in Pakistan right now. So the child mother is very close with the nurses, and she sit with them and express her feeling. She does not want to lose her child. She want to see him forever with her. Our palliative care team facilitate family to maintain legacy, or if the child have a wish, they will assist them to accomplish. So his parent talk with the nurses off and on, and also with the palliative care team. They fundraise. The mother, especially the mother, she becomes so brave that she raised funds to provide oxygen cylinders for the needy patients. Because in Pakistan, we have very limited resources for those patients who need some oxygen or nebulizers or some glucometers at home. So it's very hard for us to provide them. But he raised the money from family and from other people, and help the other patients who need that cylinders. So she feels satisfied, and our team help her to for this fundraising, and he always keep in a good memory. So the goals of our care is comfort care and encourage to have legacy and good memories of their child. Parents, emotional support during the end of life. Psychological and spiritual support after the death of the child. Social support for the funeral arrangement, which is very difficult for us because our psychosocial team is not well established, but we try to send one of our person from the hospital who try to arrange that funeral arrangements and try to help them and try to support them. So regarding the summary of the case, that is the 8 years old male child, known case of beta thalassemia major, post bone marrow transplant with the chronic GVHD lung, referred to the NABD hematology palliative care for the end of life care. Child was managed for the dyspnea, pain, constipation, nausea, vomiting, and low mood. His family was counseled and reassured that they are not alone in this difficult journey. The wish of the child to visit his native village was fulfilled, where his mood was better. Meet up with the cousins, buying a favorite drink, and he reported with a difficult breathing and chest pain. He was managed symptomatically, but could not come back. He took his last breath in the father's lap. We assist them with the transportation to the village, and the mother fundraising for the oxygen cylinders to help needy patients. So my key questions for the case presentation is, what measures can be taken to keep child comfortable, pain-free, and at least symptomatic at the end of life? How make the last days of a child a good memory? How to address the denial of close family member regarding the complication, and how to address anxiety of the child regarding outcome? How can we add life to his days rather than adding days to his life? How can we fulfill the spiritual and psychosocial needs of the family regarding grief and bereavement? Because we are in the initial stages of palliative care, So we have these all questions with the different cases. We have many cases and we are learning from these. At the time, this is the picture when after the bone marrow transplant, we discharge our patient, and this is this is a picture with the team. He was very happy with his mother, and the team was very happy because that our patient is very social and he want to go back and he want to live. So this is his physician, the nurses, the supporting staff, mother, and the child. But we not leave him alone. We are with him till the end of life. We try to make the journey comfortable. So thank you very much. If you have any question, if you have any comment, or if you want to share anything regarding the case, please you can. Thank you very much for listening.
Thank you so much, Dilnasheen. That was awesome. Great presentation. I just love how you highlight, dignity for this patient, into death. And I think that has really long-term implications for the surviving family members and caretakers when we can provide, a death with dignity. Does anybody else have any questions or maybe an example that they'd like to share of a patient?
Or if you want to share your experience, or if you want to add something that we can do more for this patient, can share your experience. Or you can type in the chat box. So
Yes, hi ma'am. Can you please explain if the patient is not ready for to accept the child is going, or what in that case what we should do when the parents is not ready to accept? In my scenario, most of the parents is not ready to accept this, that child is not alive. So how should I
yes.
do counsel?
Thank you very much, Arshit. This is very real situation. Your question is very is related to the near to the reality, because most of the parents, especially for the oncology patient who are just living smoothly after the chemotherapy or after the bone marrow transplant, they are doing well. So it is very hard for the parents to accept this situation, that the condition become worsen and the patient is no more with the parents. So the answer is that if we add the palliative care team from the day one, especially in the cases of special cases like bone marrow transplant, the special in special situation. So the palliative care team from the day one and the psychosocial team from the day one, they uh, educating or awareing the parents. They are making the mind of the parents that this is a high risk procedure. Like if the patient is leukemia, and his disease is very in the critical situation, and you know that the outcome is very hard, and the outcome is very not very good. So you have to add the palliative care team from the day one. So when they visit the parents and the patient day by day, the palliative care team can make a good relation with the patient and good relation with the parents. So it is easy for them to understand that what is going on with my patient and what will be the outcome. And when they know that this is the high risk procedure, and we can lose our child. So it is easy for them to accept this reality. And we should involve our religious persons, like the chapel, we should involve them. So because the multidisciplinary team always make the patient journey comfortable. So know that nowadays we are doing the multidisciplinary team work. So when there are many physicians or nurses or the team involved with that treatment, we can get a better result. It is easy for us to counsel the parents, and the parents listen the persons. If the palliative care team come at the end of the life, if the palliative care team come when the patient is deteriorating, at that time it is very hard for the parents to accept that or to listen the counseling of that physician or the nurse. And if he was or she was involved from the day one, they listen them and they counsel, they try to counsel them, and it is easy for them to accept that this is the end of life. We should have a good legacy, we should have a good memory for our child. I hope the answer the question.
Yes, ma'am. Thank you so much.
Thank you. So we should involve our palliative care or psychosocial team from day one, especially for those with the high risk procedure like the bone marrow transplant.
That's great, Dilnasheen. Is there anyone else that has any questions or comments?
Hello, I raised my hand. Thank you very much,
Yes. Thank you.
This is a very, it's touching because it is, palliative care, end of life care is the aspect of our work that we do not really like to do. But when you find yourself in the clinic, you have to. So it's the aspect of care we have to do, even though we don't like it. And as healthcare workers, no matter the unit where you work in, at some point, something always goes wrong somewhere. It is more in cancer care. And the reason why we feel worse is because when we know that this is going wrong, somebody has metastatic disease, somebody has end-of-life disease, there is little we can do to cure. So we can only palliate. But if you go to surgery, sometimes when they do surgery and the patient starts bleeding, they can do resection and anastomosis. If they do a C-section and a woman is bleeding, they can remove the uterus, they do that total abdominal hysterectomy, and the patient leaves maybe with something. You lose a body part, but you are still there. But in oncology, when we cannot afford cure, then we are left with this, the family. So it's like Dilnasheen just said, to be honest from the beginning, to be compassionate from the beginning. When you are compassionate, you're not just saying, you're not being sympathetic, because if you pity them, you will let them make, go their own way. You will make the families force you into what may not be helpful. And when you are compassionate, you give them the honest truth. You are gentle, you are understanding. Sometimes you use sympathy and say, sorry. But in your sympathy, the background of your practice is compassion, bringing them to a point where they will face the reality gently, very gently, can take weeks, and making sure that the patient in front of us has comfort. And sometimes comfort to a patient who is on palliation is not comfort us. It's not the way we interpret comfort. The position the patient will want to take when they are lying down, we bring suggestions, but we let them choose what is best. Don't say you must raise your head, because if at that time the patient cannot raise the head in bed, then you are bringing that patient discomfort. So there is just a lot we do. It takes a lot of counseling. It takes a lot of communication, even with the little child. And you just need a lot of grace to bring that family to that understanding. And I can imagine it is a lot of work. This family did not accept, but the way you take care of the child, meeting the child's wishes, you don't force the child to be in the hospital when he wants to see his people at home. So as much as possible, we make them, be happy with what they can have. I think this is palliative care. I am very impressed by what you did. I know that many of us are not trained in palliative care. I am not either, but I catch bits from meetings and from the practical work, like Dilnasheen said, that we just learn and we get to do it. And I think that in some years to come, you come by, because this woman now is an advocate. And I think she stands a better chance to help you even in counseling other families, telling her story and just inspiring other families. Thank you so much for all of the work. I'm very proud of that.
Thank you very much, Veera. Very good comment and very good explanation. Yes, you are right that the continued counseling and the counseling from the beginning is very important in these cases, because all cases are high risk cases, and we don't know when the relapse came, when if there's a rejection or the disease came back. So thank you very much for the comments. So if anybody else want to share the experience or any comment, you can type or you can share.
Hey, Dilnasheen, I want to thank you for that great presentation. This is Joan from Uganda. Maybe just to emphasize the need for, you've mentioned it, but it's really important to emphasize it, the need to incorporate palliative care right from the time of diagnosis, so that we've also had patients who have refused, or caregivers who have refused palliative care because they were at end of life, and they really took it the wrong way, that some were taking it in the way that palliative care only comes in when a child is dying. So they always relate it to a child dying. So, but having the multidisciplinary team and incorporating the palliative care, having the palliative care team talk to them early enough from at the time of diagnosis, keeps them with hope, and in case we are getting at that time of end of life, they have been eased into the decision, or that time, like they know what is coming, and they've been getting that talk, so it's not very strange, and it's not something that is happening abruptly, and it's not something that they will refuse and reject. So thank you very much for emphasizing that.
Thank you very much, John. Very real comment. Yes, because when we involve them from the beginning, at the time of diagnosis, it is in Pakistan and many other countries, there is a misconception. Even among the healthcare worker, they have a misconception that the palliative care is the care for the end of life, but this is not. The palliative care is a different, and the end of life is a different care. So that yes, you are very right that we should involve them from the beginning, and we can build up the therapeutic relation with the palliative care. And like in the beginning, I shared that we try to add the life to the patient's days rather than add the days to the patient's life. So we try, when the patient have only a symptom on the symptomatic treatment, we try to make the journey comfortable. And during the treatment, when the patient is going toward the curative treatment, we also try to make the journey comfortable for the parents. And that the only thinking behind this is that they are not alone. The team is standing with them. They are not alone with that child. They are the mother and the father along with the sometimes you know that the sisters and brothers of the father and the mother, the relatives are not standing with the parents. The healthcare workers, the social workers, the palliative care team, the physician, they are standing with them. So this is very good feeling for the parents that someone is standing with them as if they want anything, the financial aid, the medical support, or any other support. They are standing here, and someone is standing behind us, someone is standing beside us. So this is this feeling we want, that our parents, patients' parents should have, the caregiver should have this feeling that someone is with them from the day one. Because when we break that news, we give that paper that your child is diagnosed with the leukemia, with the thalassemia, or with the SCID, or with the retinoblastoma, or so this is very hard how to break this news. And what a parent are thinking about that, because they are not thinking about the present, they are thinking about the future. Because we are in Pakistan, in our country, in the low middle income country, the patient are paying for all these things. There are very few hospitals who are supporting the patient. Rather, the 80%, 85% patient are paying for their treatment, for their supportive care, for the blood transfusions, they are arranging their donors and all these things. So the psychosocial team, the palliative care team, they have the responsibility to share this burden from the parents from the day one, not at the end of life. So we try to do in Pakistan, we try to educate our nurses. We are trying to get educated for ourselves. We are learner. Still, I'm a learner. I try to learn how to deal with our population, because the parents from all over the world, the same parent. The parents are parents, even they are in the US, in the UK, in the Uganda, or in the Cameroon, or in the Pakistan. The parents are same everywhere. The feelings are same everywhere. Thank you, John. Thank you very much.
That was so beautifully said, Dilnasheen. I totally agree. You know, parents are the same everywhere. Everyone cares so much for their children, no matter where you live, what language you speak, and kind of brought tears to my eyes. That's really, really, really true. Does anyone else have any comments, questions? If not, we can wrap up. I do want to put a little plug in that the PSYOP Women Leadership are looking for a co-chair. And so nominations for that are open. And so if you're interested in that, we're also going to put a link to that in our next nursing newsletter, which should be out in the next week or so. And so if you're interested, please check that out. And I think that that's open to any woman in PSYOP. And as I know a lot of you have gone to some of their sessions at PsyOp. They're really amazing and they do a lot of amazing stuff. So a great group to be part of. And with that, I think we can wrap up. Thank you, Dilnasheen, so much for this presentation. It was wonderful, and we appreciate you. And thank you, everyone. I hope you have a great rest of your day.
Thank you, Shelby. Thank you, everyone, for participating, and thank you for your comment. And I hope you will think about that if you don't have that palliative care in your settings, how you can establish. And thank you very much, Shelby, for arranging so nice presentation and all these things. Thank you.
All right. Thanks, everyone. Bye.